Hey guys, hello and welcome to Speedy Medical again. So this is another video on the series of diuretics, and in this video we are going to take on thiazide diuretics. Guys, among the thiazide diuretics we have hydrochlorothiazide, we have chlorthalidone, and we have indapamide. And the principal site of action of these thiazide diuretics is the distal convoluted tubule, or the DCT. But before we look at the mechanism of action, we have to understand the normal physiology and the transport which is going in the distal convoluted tubule. So, if we talk about the distal convoluted tubule, first of all, on the basolateral side, we have an ATP-dependent transporter protein which will pump the sodium out of the cell and it will pump potassium into the cell. So as a result of this protein, the sodium within the cell would decrease. This gradient would drive another transporter protein which will pump sodium from outside into the cell and also chloride from outside into the cell. So this type of mechanism is called as secondary active transport, and I won't be going deep into secondary active transport, but this is the secondary active transport which is occurring over there. Okay. Now, on the same aspect, we have another transport protein whose function is to pump calcium from outside into the cell. And this transport protein is in turn dependent upon a hormone, a very important hormone called as the parathyroid hormone. Actually, parathyroid hormone will stimulate this transport protein and it will hence stimulate the absorption of calcium from the lumen into the cell. Again, we have a transporter protein whose function is to pump calcium out of the cell and sodium within the cell. So this is all which is happening in the distal convoluted tubule. And now let's look at what happens when we introduce the diuretics like hydrochlorothiazide, chlorthalidone, and indapamide. See guys, the principal site of action of these drugs is to block this channel, is to block this transport protein. So as a result of the blockade of this transport protein, there will be no reabsorption of sodium and chloride ions into the cell. As a result of this, the sodium ions and the chloride ions, they will be excreted in the urine, and water will also follow these ions, and this will result in diuresis and the reduction in the volume of the circulating fluid. But there is an additional thing which would happen when we will use these thiazide diuretics. It occurs that as a result of the excretion of sodium within the lumen, the sodium increases, which increases the positive potential within the lumen. As a result of increased positive potential within the lumen, it will cause the calcium to be pumped in larger amounts than the normal into the cell. Also, since the sodium is not being reabsorbed, as a result of this, the total sodium within the cell would decrease. So, the gradient for sodium to be transported into the cell would increase, as a result of which the gradient for the transport of calcium outside the cell would increase. Again, since sodium within the cell is decreased, therefore the gradient for the transport of sodium from outside into inside will increase, and simultaneously the gradient for transport of calcium from inside to outside would increase. So this is all which is happening with thiazide diuretics. First of all, there would occur diuresis because of the loss of sodium ions and chloride ions, and secondly, there will occur increased reabsorption of calcium. Now let's look at the clinical scenarios in which we use thiazide diuretics. Now the clinical scenarios in which we use the thiazide diuretics, they include all the conditions in which there is volume overload. So we have hypertension and congestive heart failure. In case of hypertension, what actually we want to do is that we want to reduce the total circulating volume. So as a result of this, when we use the thiazide diuretics, they will reduce the total circulating volume, and then hence they will happen they will help us to control the hypertension. Similarly, in case of congestive heart failure, there is volume overload within the body, so we will use the thiazide diuretics to decrease the volume. Another condition in which thiazide diuretics are used is nephrolithiasis. See guys, nephrolithiasis is a clinical condition in which there occurs the formation of stone within the urinary tract, and most commonly the stones, they are composed of calcium. Now, when we administer the thiazide diuretics, they will cause the increased reabsorption of calcium, as I already told you. As a result of this, the calcium within the lumen will decrease, and hence it will decrease the rate of stone formation. Now let's look at the potential side effects which are associated with the use of thiazide diuretics. Now the side effects which are associated with the use of thiazide diuretics, they include sulfonamide hypersensitivity. As I already told you, the drugs which contain sulfur, they tend to cause a hypersensitivity which is called as sulfonamide hypersensitivity. The second side effect is hypokalemia and alkalosis. This is again due to the fact that whenever we use the diuretics, they would cause the increased excretion of sodium ions. As a result of this, the aldosterone would be increased, which would act on the distal tubules, and it will cause the release of potassium and H positive ions and somewhat reabsorption of sodium. So therefore, it would cause hypokalemia and alkalosis, and it is also seen with the loop diuretics. Next thing is hypercalcemia. This is because of increased reabsorption of calcium. Then we have hyperuricemia. This is because in the proximal convoluted tubule, the thiazide diuretics, they are excreted via a transporter which is called as OAT transporter. The same transporter is used by uric acid to excrete itself. So whenever we use the thiazide diuretics, there occurs the competitive inhibition of excretion of uric acid, which leads to hyperuricemia. Next two are very important side effects, and these are due to the inhibition of the release of insulin from the beta cells, and these include hyperglycemia and hyperlipidemia. Both of these are contributed because of the decreased secretion of insulin from the beta cell in the presence of thiazide diuretics. This is all about the video. I hope you like this video. For more videos like this, please subscribe to my YouTube channel.